All right, so in our last video, we talked about the various changes we see in ECGs, and there's a couple more to go through. And we looked at the STEMIs and STEMIs, and we're going to now look at some ECGs to see what it all looked like. Of course, a lot of med students are very intimidated when an ECG is presented to them. So we want to look at as many as we can and really start understanding how we're supposed to navigate our eyes throughout it and really see what we're supposed to be looking for. So I wanted to first start off with the William Marrow mnemonic, which is for bundle branch blocks. Okay, so bundle branch block, like left bundle branch block, right bundle branch block, can actually be seen in many questions. And the factor that really helps you figure out, what it is going to be is looking at V1 through V6. So our next topic now was going to be starting with arrhythmias. And right here we have one for a first degree AV block patient with left bundle branch block, right? PR interval of 378 milliseconds, QRS of 200 milliseconds. Okay. In this patient here, what we're seeing, when you look at it at first glance, it obviously definitely does not look very normal. And as we further examine it, we start seeing some features that don't match some of the normal things we talked about in our last video. So for example, let me grab my pencil. So we know that AVR and V1 are supposed to point down, and that's good. So I put check marks there. Now, if you look at axis deviation, right, we're supposed to check 1, 2, and AVF. 1 is pointing up, but 2 and AVF are pointing down. So that's going to be your left axis deviation, right? LAD, right? Because in LAD, Villa, we saw that when 1 is pointing up, that's the left axis deviation. 2, 3, and AVF, we don't really see any ST elevation, so it's not a patient with inferior MI. In fact, we don't see ST elevation anywhere. So generally speaking, all we can identify now is the last thing between QRS intervals, how much space do we have, and the distance here looks like it's almost 4 to 5 boxes, right? Almost 4 to 5 boxes. So if we said that there's 5 boxes, can we see 5 boxes anywhere? Yeah, 5 boxes right here. Right, 5 boxes right there. So this is a person with some bradycardia, right? 300 divided by 5, you get 60, but it's coming off to, even sometimes we're seeing more than 5 boxes being covered. This guy is approaching some level of bradycardia as well. It's not there yet, but things are not looking so good. So that being said, all you're really seeing here is a patient with a left bundle branch block. And the one thing that really helps you cast that is the idea of your R-wave progression, right? So remember we talked about the fact that an R-wave progression is somewhat of a sine curve kind of thing happening like that, where V1 through V3 are like this, and then eventually it gets higher up when you get V4 to V6 like that, right? I heard my parrot actually walking around or something, just making sure. So if we come back to this ECG right here, that R-wave progression is heavily messed up. V4 was supposed to be the strongest guy going up like that, and it's not. In fact, the strongest is V3. So V3, remember the way these leads are placed, V3 is more towards the left side, kind of looking at your right ventricle, sort of almost between the right and left ventricle in between. So there's a block happening. Okay, when V3 is your strongest voltage, and it's pointing down like this, that means that the electricity is going away from the direction it's supposed to go. Keep in mind when we talked about this over here that electricity is supposed to be going in this direction, right? And when electricity is moving towards this bottom point over here, that's when your leads are going up. But if V3 is actually going down, even though it's supposed to be normally going up, then electricity must be going away from V3 for whatever reason, and is going away with a pretty high voltage, which means that the majority of the electricity must be going towards your right ventricle somehow, okay? Going strongly towards your right ventricle, and if that's happening, then it's not going towards the left ventricle at all, okay? Because if it was going towards the left ventricle, it would be going towards the lead, and it would actually point up correctly, but it's not. All right, so that's a sign that there's a left bundle branch block. The first degree AV block, you can't really see though. Remember with the bradyarrhythmias and the bradycardia in general, we talked about in the last video that a slower heart rate isn't the worst thing. Your heart is still filling up, and then when it pumps, it actually gets a lot of blood out to the brain and the other parts of your body. It becomes a problem when the person tries to exert themselves and do something that may require more energy, right? And their heart rate is not going to accommodate and go up. So with sinus bradycardia and many of these, one of the key things to keep in mind is, does it require treatment? Not everything requires treatment. Oftentimes you don't have to do anything, so you just let it be. And when you see such a question on STEP, it can often be very intimidating. You might think it requires treatment. You might think you need to do something about it. And you're going to look at all the answer choices and you're going to try to fit an answer choice into the question. But in reality, if the patient is asymptomatic, it usually requires no treatment. That's the case with sinus bradycardia and even first degree AV block. Just observe. Now, if sinus bradycardia becomes symptomatic and the heart rate is even lower than 40, then you may need to use atropine, which kind of mimics the sympathetic nervous system and activates or increases the heart rate. Then, maybe you'll need that. And if things start becoming really bad with any kind of arrhythmia, pacemakers are often something you can use as a definitive treatment. Avoid any medications that can worsen bradyarrhythmia, because if you take medications that further slow down heart rates, then you're going to exacerbate slowing down of the heart rate. Right? So that's a bit of a problem right there. So this is a nice ECG showing you that. I think my parrot got out of the cage and is walking around because I can hear his voice echoing from weird areas. Let me just go check that real quick. I'll be right back. Okay, yeah, he was walking around. Well, he was being a nice boy, though. He sat down in one corner, which is much better than the damage he could have done. All right, continuing on. So that's your first degree AV block with left bundle branch block. And for left bundle branch block and right bundle branch block, you use this mnemonic William Marrow. Okay, so the W and the M are for V1 and V6, as you can see in this image over here. And the L's and the R's remind you of left or right bundle branch block. That's all it is. The rest of the letters don't really mean anything. And we just saw here that this is supposed to be a person with left bundle branch block. So you can actually see the W and the M's. I've kind of traced over it over here. Right? So in V6, the M is pretty apparent. And in V1, okay, you can't really see too much of the W, but by here in V2, you can see it. I traced it in V4. Right? The point is to find it. It's never going to be extremely accurate or straightforward. Right? It's not going to be super obvious. But as long as you can find it, you're going to be able to go ahead and do it. You're going to be able to trace it out and you're going to be able to figure it out. Now here, it's even better. This one is a person with right bundle branch block, 70-year-old with MI, but the ECG only has suspicious ST changes, no ST elevation. Okay, so we still don't see any ST changes. The ST just isn't looking as normal as it's supposed to look. Like even here, for example, right here, it looks a little weird. All right, so, but more importantly, what you can see is things that don't look normal. Right, so V1 is supposed to be pointing down, it's actually pointing up, and not only is it pointing up, it's creating a very easily identifiable M shape, right? In V6, you're seeing a very easily identifiable W shape. All right, so that's your clear giveaway that this is a person with right bundle branch block. If you were checking for axis deviation, you would look at 1, 2, and AVF. You can see 1 is pointing up, 2 and AVF are kind of sort of pointing down, but not really. So it still looks like a patient with same kind of left axis deviation, which is a giveaway for the fact that LBBB and RBBB, bundle branch blocks are not really related to axis deviation. This is why when we did the topic of axis deviation, the Ralph and the Villa mnemonics didn't have axis deviation. Bundle branch blocks in them. Okay, so bundle branch blocks, are not really associated with axis deviation at all. The axis deviation is more related to other things like actual damage to the heart, actual movement of electricity in certain directions with more impact, not the blocking of electricity moving in the correct direction. Okay, here we're just blocking electricity from moving in the correct direction. So you can see that it obviously has some alteration here, but it's not really an identifiable alteration. We can't say that right bundle branch block is always going to have left axis deviation. It can have right axis deviation also. So the relation is not one-to-one. Of course, you will see it though, because there is a blockage of electricity moving. So some electricity must be moving in a different direction, but it's not enough to actually deem which axis deviation occurs with which bundle branch block. That's what I'm trying to say. So there's no connection, okay? This image is really nice to show you what leads are significant for different kinds of evaluations. So when you're looking at certain leads, you're looking at significant parts of the heart. So when we care about the inferior part of the heart, which is related to the right coronary artery, we look at 2,3 AVF. And more recently, the more significant MI topics that are popping up are the ones related to the anterior MI. So that's the pinkish area here, leads V3 and V4, right? You have your lateral leads and then you have your septal leads. If we look at these diagrams here, these ECGs right here, the first one up here is showing you an inferior ST elevation MI. You could clearly see an elevation marked by the red lines in 2,3 AVF. If we look at the whole thing first though, V1 through V6, we could see that there is some arm wave progression, but it's not that normal. It's not that normal. V4 is supposed to be the tall guy. It's not. Right? V4 is not your super strong R wave. In fact, it's V2 being strong. Okay, and then in 2, 3 and AVF, you can see that the red line here, I'm showing you the baseline. In 3 and AVF is most apparent. Okay, it's high. The ST is elevated. All right, so this is a patient with inferior ST elevation MI. This ECG here is showing you a patient with an anterior ST elevation MI. There's clear elevations marked by the red lines in V3 and V4. In fact, they're extremely obvious. The ST is super elevated. The R wave progression is completely abnormal. V1 is pointing up when it's supposed to point down. V4 is supposed to be super tall. It's kind of not really getting much electricity. The voltage is very bad here. Okay. Voltage is bad in V3 also. V3 and V4 are supposed to be the tallest, if anything. But they're both kind of not so tall at all. V5, there's barely any electricity. V6, there's barely any electricity. Right, the parts I circled are showing you also ST elevations. So obviously more of the heart is being affected in that patient, right? So some of the septal and lateral leads are being affected also. But the major person that's being affected here is the anterior lead. That's the part that's giving away the fact that this is an anterior MI. All right. If you look at the rest of the heart though, you see just, voltage fluctuations. There's just not enough voltage being delivered, so you have weaker QRS complexes. Here we're looking at now things related to what we have on this page, right? So sinus bradycardia, first degree AV block. You're seeing in the same ECG both things. This patient also you see 1, 2, 3, 4, 5, 6 boxes. 6 boxes, 6 big boxes in between QRS complexes. So that's 300 divided by 6. That's 50 beats per minute heart rate. That's pretty bad. And then the AV block, there's only one place that's a giveaway that there's an AV block in this patient, and that one place is right here. Right, that one place is work with me. There you go. This portion right there. So you can see that QRS complex is slightly off the baseline, right? You can see this weird, almost ST elevation type of thing happening, and that's happening because there's a P wave that's happening at the same time as you're getting the QRS to come to an end, thereby elevating it. Usually the P wave is supposed to be occurring before, but it didn't really. There's no good P wave here. Right, so the P wave is kind of not happening regularly with the QRS complexes. It's not always going to be super obvious and you can't always see it, but what you clearly see here is there is bradycardia. Okay, so first degree AV block is really only apparent because of this portion here. You usually won't even really catch that, and it's usually not really visible, and that's okay because it doesn't really require treatment, so you don't need to identify it. The more significant thing you do need to identify are the second degree AV blocks, right? Type 1 and type 2. There's a Mobitz 1 Wenke back. That's the second degree AV block type 1. And then there's Mobitz 2. Now, if you've ever been confused about identifying the difference between the two, then this should help make it more clear, okay? So if we look at this image here, the first one here is second degree AV block type 1, and the one down here is a second degree AV block type 2. So what's the difference? How do you memorize them? Second degree type 1, you have a person with one drop QRS as the PR progressively lengthens. In the languages of Hindi and Urdu, PYAR, P-Y-A-R, PR is love, okay? So what you want to memorize for this is you found the one, you progressively fell in love with them until your heart skipped a beat. That's really all. That's it. Super easy memorization, okay? You found the one, you kept falling in love with them progressively, and then you skipped a beat. And that's what you're seeing here. So if we look at this ECG, the bottom part is often given as any one of the leads. So when you look at an ECG, most times when we study ECGs, we only see this portion. And this portion can be any one of these leads, but a longer strip, okay? You want to look at the longer strip to identify any fluctuations that are occurring over time in terms of regularity and rhythm, okay? There should be regular distance between QRSs, there should be good rhythm, there shouldn't be any fluctuations like that, right? We do see fluctuations. I highlighted it over here, and then here it's not being highlighted, so you can see it here as well. What you're seeing is that the PR keeps getting longer, okay? Where this one is the longest one. The distance from the tip of the P to the first impact of the QRS, right? That's the line I made, and you can see that it keeps getting longer, and then all of a sudden there's a QRS missing. That's what I drew here, okay? So this is type 1, okay? Found the one, kept progressively falling in love until you skipped a beat. This one down here is second degree AV block type 2. So in type 2, you're going to have randomly dropped QRSs with normal PR intervals. So the PR will not be lengthening. Okay, so here you can see P to R is the same distance each time. Okay, the distance from the P to the R is not changing. Right, so P to the QRS interval, that distance is not changing. But here you can see from this P to the QRS interval is basically one big box. Okay, one big box. That's a pretty long PR interval. And that's not the case everywhere, though. In some places the PR is a little less than one big box, and some of them is about the same one big box distance. It keeps lengthening, and then all of a sudden you have a QRS that's dropped. It's not always going to be super apparent, but you have to do your best to find it. In this case scenario, it's super clear to see that all the PR intervals are equally distant, and they're a pretty good length. It's not one full big box in between. Okay, so 0.2 seconds is one full big box. We don't have that. We have less than that. And then randomly, you're missing QRS complexes, right? You're missing one right here, right? You're missing one right here. So, and even over here. See, in this area right here, you're just missing one. After this happened, you're just missing one. Then you have 3 normal things. Then you're missing one. Then you have 4 normal things. Then you're missing one. Then you have a bunch of normal things, not missing one at all. Nothing missing, right? So you wanna catch that. You can see that in multiple other leads as well. Very good, very nice ECG. All right. For both of these, the second degree type 1 and second degree type 2, you can use atropine. And generally speaking, if the patient is becoming symptomatic, you may need a pacemaker. Okay. The type 2 could actually be due to fibrosis of the conduction system in a person who recently had an MI, right? If it recovered, but the fibrosis messed up the conduction system, so there's an AV block. For these patients who have these scenarios, the majority of the treatment is really just based off of symptomology, right? You just have to work with the symptoms they're appearing with. A little note here, very good key thing to keep in mind. Exercise, which is decreased vagal tone. Remember, vagus nerve is parasympathetic, vagus nerve is just rest and digest. Exercise is a sympathetic thing, it's fight or flight. So exercise, or basically anything that decreases vagal tone, will actually improve type 1 block, but it'll worsen a type 2 block. So let's try to make sense of this, right? Because this is something that can be given to you in a question. This is more significant for step type of bullshit. So what was the problem in type 1? The distance between PR was increasing, your heart rate was slowing down, and then you missed the QRS. So by doing exercise, you're actually able to improve the type 1 by decreasing the distance between PR intervals and hopefully not dropping on QRS. Okay. So why would exercise worsen type 2? Well, in type 2, right? You're randomly dropping QRS complexes. Now imagine this person tries exercising. They need more QRS complexes. But randomly dropped QRS complexes, anything random is usually hard to fix. So if this person needs a higher heart rate and they start exercising or something, they're still going to have, all they're going to end up doing is have more missed QRS complexes. Right? Imagine there's a machine out there that randomly forgets to create something after every 3 times of creating it. Now you speed the machine up, it'll randomly miscreate even more. Okay, so that's what's happening here. Exercise improves type 1 block but worsens type 2 block, which fits the scenario that it was a person with a previous MI, because you don't tell previous MI patients to really exercise, right? That can further worsen the recovery of their MI. So that's what I'm explaining here, that the AV node impulse time, or the AV delay, shortens with exercise. So that actually fixes the prolonged PR in type 1 block. But over here in type 2 block, if you exercise, you actually need more QRS complexes, right? You need to double your heart rate sometimes. They're not going to be able to. They're just going to have more missed QRS complexes, and that's going to be a problem. So very critical thing to watch out for in a question. This can be given to you in a scenario in a practice question, and we're going to see some soon enough. And in those scenarios, you can easily kind of miss what's going to happen if you don't catch it, right? If they tell you, oh, when this patient exercises, the condition worsens, well, that's probably a type 2 block, right? Last thing here is a 3rd degree AV block. Now, all these blocks are in step 1 as well, but here it gets a little more serious in CK, and it's more likely that you'll get a ECG for the question. So for 3rd degree AV block, usually due to Lyme disease, patients can have syncope or heart failure. Note Canon A waves on the JVP tracing. P waves may be blurred behind QRS complexes. And here, in this case scenario, you have to put a pacemaker. There's no dodging that, okay? Have to put a pacemaker. So now, scary scenario here. We're talking about the JVP tracing, right? And I have a picture here, one of my favorite pictures to really understand the JVP tracing or the CVP tracing, and connecting it to the ECG, okay? Really significant little topic. You want to be able to go back to step 1 and revise it. We're going to talk about it right here. So what do we have here? So with the JVP tracing, you have your A, C, X, V, and Y. They follow this simple cardiac action, okay? A is for right atrial contraction. C is for right ventricular contraction. So let's stop here and kind of really break down what's happening with them, right? So we're looking at the blue area here, the right heart, right? Because that's what the JVP looks at. And ECG mainly looks at your left heart. If you look at it, every time, what's happening in A and C? So when your right atria contracts, some blood will go up. And majority of your blood is being pumped into here, right? That's the scenario with your right atria contracting. When the right atria contracts, there's no valve in the vena cava. So some blood will go back up the supravena cava, but the real goal of contraction here is to press hard enough to open the tricuspid valve and shunt blood into the right ventricle, okay? So when the right atria contracts, some blood goes up, and that's how you get the A wave, right? Now, when your right ventricle contracts, that's C, right ventricular contraction. When your right ventricle contracts, of course, the majority of the goal is to open the pulmonary valve and send blood in this direction. But there's going to be some pressure into the closed tricuspid valve, right? It's going to push into here. Blood won't go back because the tricuspid valve is closed. We're assuming it's working. But the pressure will still cause some blood to be pushed here. It's like pushing a wall, and then if someone's on that side of the wall, or pushing a door, and if there's someone on the other side of the door, they get pushed back, right? So that's what's happening here. Some blood is being pushed up this way, but not as much. So that's why it's not as high. And that's how you get the C, okay? So now A and C is super straightforward, okay? You can already imagine where they're going to be messed up, right? So if A occurs when right atria contracts and this goes up, then something must be causing right atria to contract a lot more if you have big A waves, right? Note Canon A waves. 3rd degree AV block has Canon A waves on JVP tracing. That's the most significant thing about the A wave, okay? It's related to 3rd degree AV blocks. When C occurs, that was from right ventricular contraction against the closed tricuspid valve. If the C is not there, then the tricuspid valve must be regurgitating or something. You know, if it's regurgitating, then a lot more blood is going to come back and C is going to be bigger. If the C wave, if the tricuspid valve is just suprastenotic, then not much is going to occur here. X descent. So X descent is right atrial relaxation, right? Remember, these are pressure readings in the jugular vein. How much blood is there? So the right atria is relaxing. Blood is actually coming into here from the superior vena cava. So pressure pretty much goes to zero, right? Right atrial relaxation. So if for some reason your right atria is unable to relax, then the X descent won't be that good looking. Okay. Then V is for villing or filling. Okay. V is for filling that right atria after it just finished relaxing. Okay. So if it just finished relaxing, now you're going to add blood into it. And as blood is being added into it, eventually it'll fill up, and then some blood is going to start piling up, and blood is going to be up here. So you get a bit of a pressure buildup. Right? There is pressure, of course. You literally started filling it up, so a lot of blood is just bouncing up and down. And then the Y is right ventricular relaxation, where the tricuspid valve opens, so blood is going here, and there's no pressure backwards. Super simple stuff. And it all associates to the ECG and systole and diastole. Remember that the P wave is atrial contraction, right? Atrial contraction. As soon as atrial contraction is done, it's ready to start filling. So that comes into the whole diastole of the ventricles, right? Ventricular diastole is when atrial contraction is occurring, right? So that's something that you're seeing here. And ventricular systole was the QRS, right? The QRS occurred, ventricles have contracted. Around that time, when the ventricles are contracting and sending blood out, the atria are trying to relax, right? So atrial contraction is done, and now you have the X descent, which is right atrial relaxation. Right? So X is right atrial relaxation, and this A again is going to be back to going into right atrial contraction once again, and so on and so on, looping, looping, looping. Now, these Canon A waves that we just talked about for your third degree block, this is what it looks like. So you can get a JVP tracing that looks like this. Okay, you can get Canon A waves. So A waves that are just really big. Nothing else occurs. It's just a big A wave. You don't even get the whole thing because the A wave is so big, the rest of it got altered. All right. So in between normal JVP tracings, you're going to have Canon A waves. That's a sign that there's atrioventricular dissociation, atrial contraction against the closed tricuspid valve because the tricuspid valve was either contracting when it shouldn't be. Why would the tricuspid valve be closed? Because the right ventricle is contracting. But if the right ventricle is contracting at the same time as the right atrium is supposed to contract, then now the right atrium is going to be contracting against the tricuspid valve that will not open because the pressure in the right ventricle is too high. Those guys should not be contracting at the same time. So if they're contracting at the same time, then you get big A waves because when the right atrium will contract, all the blood will actually go backwards up the superior vena cava. That sucks. Last topic in bradycardias is your sick sinus syndrome, right? Sick sinus syndrome. So sick sinus syndrome is a bit of a more confusing topic, in my opinion. Very rarely tested, but we do have to know it. Before moving on, let's actually look at these ECGs, by the way. So above and below both of these are showing you third degree AV block. The most notable feature here, right upon looking at it, should be the immense distance between QRS complexes. Like this is a person with a significantly slow heart rate. In fact, it's given that the atrial rate is 60 and the ventricular rate is 27, half the atrial rate. Right? There's a slow ventricular escape rhythm happening or a junctional escape rhythm happening, and things are going really bad for this person. This person can die. Okay, they can die. So with third degree AV block, you actually have to give a pacemaker. There's no other alternative. You have to give a pacemaker. In this one here, same kind of thing you're seeing, not as slow as that person, but it's still a very slow heart rate. So you have 1, 2, 3, 4, 5, 6 big boxes in between. All right. So very slow heart rate. You're seeing P and the distance between P and here also being very big. Okay, so PR interval. Only lead 2 is shown. This is all lead 2. That's another thing to keep in mind. So It helps sometimes to look at one lead, but look at a very long time period of it, right? So we have the same lead, but over a very long time period. Atrial rate is 85, but the ventricular rate, once again, is half of it, 42. Right? So that means that there's atrioventricular dissociation. Only every other time the atria contracts, the signal actually reaches the ventricle. Ventricular rate is half, so atrial impulses are not being conducted to ventricles. Right? Again, all you have to do is give a pacemaker. Now, when it comes to sick sinus syndrome, almost all the charts for sick sinus syndrome look just like this. Okay, some variation of this. It's not exactly one of my favorite things to talk about. It's a very intimidating topic for a lot of med students. But what you really want to catch in sick sinus syndrome is the sick aspect. It's usually a patient that is very sick. They're not doing so well. All right. So you're going to get a patient who's kind of maybe just had an MI, has a couple of other heart conditions, not really doing that well in terms of health, has other comorbidities like diabetes and hypertension, and you're gonna have to figure out how the hell are you gonna help them. But again, not always the easiest thing. The most common type of sick sinus syndrome is tachycardia bradycardia syndrome, which has atrial fibrillation and thromboembolism possible. Can lead to a transient ischemic attack or stroke. Pacemaker and anticoagulation will be necessary to prevent systemic emboli. They can also have fainting, which is often referred to as a Stokes atom attack, fainting due to asystole or ventricular fibrillation, common in elderly after scarring degeneration post-MI. But it can be also a patient with COPD, really bad infection and COPD, other things. They're just really, really sick. Right? That's the most important thing. In general, if a patient has a pulse under 50, then you should assess for any underlying causes based on their symptoms, age, and comorbidities. If they have signs of shock, mental status change, cardiac ischemia, or chest discomfort, start them on IV atropine 0.5 milligrams every 3 to 5 minutes, up to 3 milligrams max. Otherwise, just monitor and observe. If atropine doesn't help, consider transcutaneous pacing, IV dopamine or IV epinephrine. Dopamine also being great for keeping the kidney in shape. But ultimately, transvenous pacing is the definitive treatment, a pacemaker, basically. Right? That's the most significant thing here. So if you look at this ECG, it's kind of designed in a weird way. So you have your V1 through V6 on the right side still, but not the same way we usually look at it. It's usually V1, V2, V3, and then V4, V5, V6, but they put it like this. Either way, if you look at it, lead AVR is pointing down like it should. Lead V1 is pointing down like it should. So those two things are going good. The pencil is not working too well anymore because I guess the asked me over too long. I don't know what. V4 still looking like the good tallest guy. R rate progression looks pretty decent. If anything, I would argue that the R rate progression did get a little messed up between V2 and V3. Right? This is really strong. And then V3 is looking more equidistant. And V5 looks like the big tall guy. But there is R wave progression. Between 2, 3, and AVF, 2, 3, and AVF, I don't really see any ST elevations. The most notable thing I'm seeing is there's a bunch of QRSs missing along the whole thing right here. Right? There's an irregularity, right? This is this much distance, and then the other one is a lot more distance. Okay, so there's some irregularity. ECG from a man with tachycardia bradycardia syndrome following mitral valvuloplasty. Resection of the left atrial appendage was a very common thing you have to do. There's usually a little pocket in the left atria that can form in elderly people. And in that pocket, blood can accumulate. And then at some point, because of atrial fibrillation, it can come out as a thrombus. So you have to get rid of that left atrial appendage. Or there's also something called the Watchman device, which I've talked about in my step 1 videos. You could fill that hole with the Watchman device so that the hole will no longer be available for blood to accumulate inside of it. He also got a Mace procedure, which I'm not sure what that is. The ECG shows AV junctional rhythm resulting in bradycardia at around 46 beats per minute. So this is your little weird ECG that you would see in patients with sick sinus syndrome. The other half of the topic is your tachyarrhythmias, people who have a high heart rate. With high heart rate patients, you really got to figure out like what's causing their heart rate to go up, because there are many things we can do to increase our heart rate. There aren't many things we can do to slow down our heart rate. The only way to really slow down our heart rate is to rest and just, sleep or something really relaxing, and your heart rate will be normal. But if it's slower than normal, there's very few things you can do besides taking medication to really slow it down, like a beta blocker. With tachycardia, though, there's a lot of things you can do to really cause your heart rate to go up. All right. So first thing we see here on the topic is sinus tachycardia, a heart rate of more than 100, sometimes more than 150, but with normal sinus rhythm. Right? You always want to check rhythm and rate. If the rate is high, is it at least rhythmic? Because if it's not rhythmic, then you have your diagnosis. Palpitations are common in sinus tachycardia, but usually it's just due to a normal response to fear, pain, exercise, but could also be due to hyperthyroidism, infection, and fever, or a pulmonary embolism, all of which would have different symptoms involved, so you would figure that out. And all you have to do is treat the thing that's causing the sinus tachycardia. The more significant thing is your atrial fibrillation. All right. So with atrial fibrillation, you have a CHADS VAS score you could look at, and this is your ablation that you're supposed to do to kind of fix it. So let's take a look at what's happening. You can have a patient with irregular pulse, can be incidental or present with palpitations, could lead to shock, heart failure, or even cerebrovascular accident. CHADS score predicts the risk of stroke. Right. So this is used to see, is your patient likely to somehow end up getting a stroke? If you look at the CHADS VAS score, congestive heart failure, if the patient has it, you give them 1 point. Hypertension, age, more than 75 or age 65 to 74. Okay, the A's stand for the same thing. You don't give all the points. So you either give 2 points if they're over 75, or you give 1 point if they're between 65 and 74. If they're under 65, you don't add any points. Okay. Diabetes, prior TIA or stroke, any vascular diseases, and if they're a female, you add a point also. Right. So these points are then used to kind of figure out if you need to give them anticoagulation to prevent stroke. Generally speaking, any patient you give atrial fibrillation, you just give the anticoagulation anyway. Because think about it, all you need to do anticoagulation is more than 2 points. You easily get 2 points from hypertension and diabetes, which is pretty much 90% of Americans. So then, as soon as they have any one of these other things, being female, being elderly, vascular disease, there's heart failure, prior strokes, then you instantly have enough points. So you pretty much just give anticoagulation. It's not really, in my opinion, it's not really something that useful, because I don't see why you would do the score. Just give anticoagulation unless it's contraindicated for whatever reason. Now you have to do rate conversion with rate control with beta blockers, calcium channel blockers. You can use digoxin, especially if they have heart failure. Digoxin will be helpful. Synchronized cardioversion. So remember, synchronized versus desynchronized is a thing. We're going to see that soon enough. But synchronized cardioversion is what you want to do for patients with unstable atrial fibrillation. And then in the end, if it keeps happening and it's a problem that you're not fixing, you have to do radiofrequency ablation to fix the ectopic foci within pulmonary veins. This is an answer in many Q banks, where they're gonna, instead of saying do radiofrequency ablation, they'll make sure they mention where you do the ablation. All right, so ablation is actually done here by the pulmonary veins. So keep in mind, let's see, right here in the intraatrial septum area, you have your AV node, right? You have your SA node by the supravena cava. The AV node is here. It's sending impulses, right? But there's some other thing here, some ectopic foci that are also sending impulses, causing your atria to contract, and you want to get rid of that, right? So you do some electrical ablation, and you form ablation lines, and you get rid of the area that's making more electricity, right? Thereby normalizing the atrial contraction. This image here, this ECG is showing you atrial fibrillation. You have an irregular rhythm. So there is irregularity, right? You can see these two are between, these two only have 2 boxes in between, these have 3, these have 3, and then if you look at the longer version, which helps to see it even better, right? You can see the distances is not, there's no pattern. See, there's no pattern in between the lines I drew, right? Is it medium, small, medium, long, medium, small, medium, small, medium, small, small, medium. Very, very irregular, no pattern. And then in general, it's an irregular rhythm. So you get irregularly irregular, the most common kind of irregular rhythm. You have an absence of an isoelectric baseline. So I drew the isoelectric line of where it's supposed to be, and you can see that it falls off of that sometimes, especially in the longest one. And a variable ventricular rate. If you click on the red line, you can delete it in a PDF editor for yourself if you buy my notes. Right. So that's your atrial fibrillation patient right there. You also, of course, can see some weird stuff happening here in V1. So that's pretty significant. And throughout the ECG, it just doesn't look that normal. Right? There's no way you can say this is someone that's normal. This ECG is going to be for slow fast AVNRT, and we're going to get there pretty soon. Before that, we have a few other easier topics in between. So atrial flutter, classic sawtooth appearance of P waves, same treatment as for atrial fibrillation, rate control, rhythm control, anticoagulation. Multifocal atrial tachycardia, MAT. This is multifocal and also multi-etiologic, so it's often associated with COPD and hypoxemia. You have multiple atrial pacemakers or reentrant pathways leading to at least 3 different P wave morphologies. Okay, honestly, couldn't find a good ECG example for this to share, but basically, if you're seeing P waves in the same thing that are looking very different, so mainly you're going to want to look at the bottom one because that's the longest time. If you see multiple different types of P waves in there, and the patient has a history of COPD and now presenting with some kind of tachycardic issue where the heart rate is high, it's probably this. Okay. Treatment is the same as for atrial fibrillation. However, you don't give beta blockers because you're not supposed to give beta blockers to COPD patients, right? Beta 2 receptors are on the lungs. You could give cardiac specific beta blockers that only work on beta 1 receptors, but even that is often avoided. General chronic lung disease patients shouldn't be getting beta blockers. So that's generally all there is. So treatment, thankfully, is very nice for all of these guys. You just do the same thing you would do for atrial fibrillation. And then here I'm showing you what it all looks like. So multifocal atrial tachycardia, atrial flutter, atrial fibrillation. And here in the multifocal, you can see this P wave, this taller, weird looking P wave, and then this is a downwards pointing P wave, all in the same lead 2. And it is tachycardic, right? Because there's between these two guys, there's barely 2 boxes. So there's a high heart rate. We even have a missing QRS, right? So multifocal atrial tachycardia. Now here comes the bigger guys, AVNRT and AVRT. So YouTube has really nice videos. There's a couple where they talk about the differences between AVNRT and AVRT. Generally speaking, the difference is in the name. Right? It's in the name AV nodal reentrant tachycardia. So the node is the problem, whereas AV reentrant tachycardia, the issue is not the node, not the AV node. So these two images, when I click on them, they actually play a scene. So here you can see, right, the impulse came from the AV node, and then it came back into the AV node. Very important to catch that, right? The impulse coming from the AV node and then goes back into the AV node, causing a second circular looping right here. So you're gonna essentially end up causing your atria to contract, and then contract again while the ventricle is contracting. Normally, is atria contracts and then atria relaxes while ventricle contracts, right? And they take turns. But now you're gonna have the atria contract, then the ventricle is gonna start contracting, and the atria is gonna contract again. That's gonna be a problem because now you're gonna have an atria contracting against a closed tricuspid valve. You're gonna be able to possibly see canon A waves. In this image here, what you're seeing is the AVRT. So you see now you have 2 sources that are causing the ventricles to actually contract. And you end up getting something called the delta wave, which should ring a bell for you for Wolff-Parkinson-White syndrome. Right? So Wolff-Parkinson-White syndrome is a type of AVRT, but it's got its own case scenario. But what's different here compared to AVNRT is that there's no loop in the node. Okay, so the AV node is going to send an impulse, right? SA, and then the AV node is going to send an impulse, but there's another thing over here that also already sent an impulse. So you have this slurring delta wave right there. Okay, shorten the PR interval. I remember the PR interval is the amount of time you have for the atria to put blood into the ventricles. Right? So these patients, whether you're going to pick one answer or the other, usually just depends on the ECG, but also can depend on what information is given about the patient. But majority of the time, the answer just will be AVNRT. It's not. I haven't seen anything where they want you to pick between AVNRT or AVRT. They would actually have to give you what's happening electrically in the nodal and non-nodal aspect of things to figure out which one of the two it is. Okay, you can't just differentiate it based off of a simple question stem that doesn't tell you what's happening in this aspect. So here you're seeing a slow fast AVNRT. The slow fast AVNRT is the most common. There's other variations also. You also have fast, slow, 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 all kinds of things like that. Um, this is very confusing a lot of times when you first start learning about it. What is this talking about? Well, there's a slow conduction pathway, there's a fast conduction pathway, there's a couple weird things like that that are happening at the same time. And you really want to make sure you don't look into it too much because it can become very confusing and annoying very quickly. So don't bother yourself with it way too much. But your AV node has two pathways, right? So if we are going to look into it, let's really make sure we look at it correctly. And again, QBanks do tend to explain this pretty well. But your AV node has two pathways. It has a fast pathway that has a long refractory pathway. Okay, so it's fast, as in the impulse travels very fast, but then it has a long refractory period, so it takes a long time for it to be ready to send another fast impulse. Okay, so when it sends an impulse, it sends it fast, but then it takes a long time for it to get ready to send it again. Okay, that's the fast pathway. Then there's a slow pathway. The slow pathway sends a slow signal, but then it's instantly ready to send it again. So it has a short refractory pathway. Right, so it's sending a slow signal, but it doesn't have a very long time to be ready to send it again. So you can either send a fast signal and then wait a long time to send another one, or you can send a slow signal and then not wait long and send another slow signal. So you can imagine eventually, if this is going to happen, right, eventually there's going to be a time period where both signals come at the same time. And that is where the problem ends up happening. Okay, so you get this AV nodal reentry tachycardia, where for some weird reason both signals reach the same time, and then one ends up causing itself to reactivate and cause the atria to contract again, even though the other signal reached the ventricle and the ventricle is about to contract. So now your atria and ventricle end up contracting at the same time. This AV nodal reentry tachycardia, this kind of thing is a very high yield topic when it comes to ECG type questions on CK. And you really want to make sure you have it down correctly. So I'm going to talk to you about some questions. First one, we have a 28-year-old woman comes to the emergency department because of palpitations. She's got a feeling of her heart racing for the past 3 hours. So first thing you're noticing in that statement I made is this pretty young woman, 28, and she's getting palpitations, heart racing, so tachycardia. Over the past year, she has had similar episodes that actually were able to resolve with deep breathing, but this episode kind of lasted a lot longer. She has no chronic medical conditions, doesn't really take any medications. She doesn't really do any drugs or anything like that. No smoking. When you check her vitals, her pulse is 164. The neck is actually fine, thyroid is fine, lymphadenopathy is not present, and the lungs are fine. Then they give you an ECG, and the ECG will look something like this. Okay, so then they ask you what's the most likely cause of her symptoms, what's happening. Okay, and the correct answer choice here will be two distinct conduction pathways within the AV node. Okay, two distinct conduction pathways within the AV node. A fast pathway with a slow refractory period, and then a slow pathway with a fast refractory period. Okay, and at some point they're both going to send a signal at the same time, and then that's going to cause a problem and cause the AV node to activate twice, right? Active and cause right atrial or atrial contraction, left atrial contraction twice. Okay, so the left atrial will contract, and then it'll contract again while the ventricle is contracting. That's not going to work out too well. This topic, how do you even get to this? Well, first things first, when you look at this, you can see this is tachycardia. We barely fit two boxes in between QRS complexes. Okay. But what else can you see here to actually pick AVNRT? Well, if your patient has no reason to have tachycardia, nothing fits. Like in the scenario I just discussed right now, the question that I was kind of talking about right now, we saw no reason for her to have tachycardia. She randomly tends to get palpitations, and the only thing that fixes it is deep breathing, which is kind of a relaxation method, right? So she's trying to activate parasympathetic feelings to then slow down her heart rate, rest and digest. But she doesn't have hypertension. She's not a history with MI. She doesn't really have diabetes. She doesn't take any medications. Nothing is wrong. So then the only explanation is that it must be AVNRT, that her AV node has a nodal reentrant tachycardia. Not AVRT, because we have no reason to pick that as a choice. There wasn't really anything given saying that there's an ectopic place sending any signals, and also because we don't really see slurring. We don't see slurring. We don't see a delta wave. Remember here, AVRT often has the Wolf Parkinson so White type of slurring. We don't see that anywhere, right? There's no slurring here. It's very nice and sharp. All of these very nice and sharp QRS rise. So that's something to watch out for if you ever have to pick. This one here is showing AVRT. Okay, no, narrow complex tachycardia. Right. So at first glance, clearly the two ECGs are very different from each other. The only similarity is the tachycardia, where once again this looks like literally one box in between QRS complexes. So it's a very high heart rate, right? Very, very, very high heart rate. But you do see slurring now, right? You can see the slurring. For example, let's see, well, if we're just going to look at the longest lead, just look at how it looks. It doesn't look as nice as it does here, right? You got this like weird curvature here. It's not a sharp rise. Sometimes it is. This is a sharp rise. Sometimes it's not. It's got this curvature. And also you're not on the same line, right? You're not on a line here. The P didn't come back all the way because the QRS had already started going up. And so the P wave was supposed to go up and come down. Then you get your QRS, right? And then you get the T. So what you're seeing here is that the P wave went up, and then it was supposed to come down, but your QRS already started coming, which means that the QRS started here somewhere, right? And it's eating up some of the P wave's descent time. So that shortened this distance here that's known as the PR distance, which is supposed to be the amount of time you have for blood to go from the atria to the ventricles, okay? So that's what you're catching here. This is a very narrow complex tachycardia. Very narrow, right? The amount of space in this entire area is very tight. It's like you took an ECG and just squished it together. And that makes sense, right? Because you have your AV node sending a signal, but you also have this other area sending a signal that's messing it up. That's the SA to AV. And before the AV node could even send it, this other guy had already sent it. This is why you already had this ascent before your P could even come back down. So the P wave didn't even come back all the way down. That's what we were seeing here. So the difference between these two ECGs is subtle, but it's after enough practice and after hopefully watching this video, it's much more clear and much less subtle. Right? There's another AVNRT question. So you get a 25-year-old woman, again, young woman, coming in for occasional episodes of palpitation. Sometimes she just gets palpitations. So if a person ever comes in to tell you, oh, I tend to get palpitations, you're going to explore what it is that she does that possibly causes palpitations. She describes that the episodes are usually sudden, they have abrupt onset, and she ends up feeling like her heart is racing in her chest. The episodes are commonly unprovoked, not related to any exertion. During one episode, her heart rate was 185 and regular. She has no significant past medical history, doesn't really take any medications, no family history of heart disease. Physical exam is fine, no heart murmurs, no sounds that are pathological. She reports that she's been self-treating by immersing her face in cold water, and that kind of terminates her palpitations. Generally, she tells you that the cold water immersion relieves her symptoms within minutes. This maneuver terminates the palpitations by altering what pathway? So, of course, you should be able to see a similarity between this scenario that I just read about this 25-year-old woman and the other 28-year-old woman before this. Both of them mentioned a way that they were able to figure out how to fix the palpitation. They both found ways to do something parasympathetic, right? One of them was talking about in the previous question that they would take deep breaths, and then this one, cold water immersion, both of which are relaxing things. Okay, if you get in cold water, you're freezing, which means you're not moving anymore, which means you're relaxing. Okay, as in hot water is more of a tachycardic thing. So by doing this cold water immersion, the answer here was she's altering AV node conductivity. Okay, she's slowing down her heart rate, which gets rid of the palpitations. And this was also a patient with AVNRT. It's almost never AVRT unless they give you an ECG like this with really slurred waves and really narrow complex tachycardia, right? Whereas AVRT, as I said, is also a type of WPW, right? So WPW, when you get to the idea of WPW, you're going to see how that's a little different, and we're going to look at that. So we're done with that. We're done with this ECG, which we just looked at. Right, QRS complex, definitely tachycardia. Treatment is cardioversion if they're hemodynamically unstable, or vagal maneuvers if they're stable, which in our questions that I talked about, they were doing, right? So Valsalva stuff, carotid massage, ice immersion for dive reflex, all of which slow down the AV node. Adenosine is the main treatment if vagal maneuvers fail. Okay, recall from step one, adenosine works with adenosine A1 receptors that induce negative chronotropy, so they slow down heart rate, and negative dromotropy, slow down conduction speed, by inhibiting the adenylyl cyclase in the AV node. The below ECG here shows improvement of the same patient that we were looking at with the AVNRT after adenosine is being given. So you can see now there's at least about 3 boxes between QRS complexes. Things are looking a little more normal. Wolff-Parkinson-White syndrome, basically a type of AVRT that originates from an accessory pathway called the bundle of Kent, causing a characteristic delta wave. Treat acutely with procainamide or amiodarone. The supraventricular tachycardia gets worse with AV nodal blocking agents like adenosine, calcium channel blockers, or digoxin. So, you got to be careful and check what medications the patient is on, which is always the case. Radiofrequency ablation is curative. Okay, so here this is Wolff-Parkinson-White syndrome where you're not seeing the AVRT type of narrow complex tachycardia. Right? This is the difference between AVRT and then WPW, which is a type of AVRT. AVRT looks really crazy, super tachycardic. WPW, it's not that tachycardic. Right? The red circles show the characteristic delta waves throughout the ECG. Right? You have a slurring. It's not a sharp rise. Right? And the most significant thing is that the PR distance is too tiny. So there's not going to be enough time to fill the ventricles, and that often ends up causing some level of palpitations and syncope and weakness. The other notable feature here is that V1 is actually pointing up when it should be pointing down. Right? So that's not good. V1 should be pointing down. AVR and V1 should both be pointing down. It's not. AVL should be pointing up. It's pointing down. Heart rate progression, other than V1 pointing up, is looking pretty normal. 2D AVF look fine. There's no ST elevation, so there's no MI. Right? And then that's generally it. So you work with these things to kind of figure out what's happening with the patient. Very important to make sure you can understand that. Other than that, they have some other little things that they talk about, like paroxysmal atrial tachycardia. So this is overnight. Rapid ectopic pacemaker in the atrium, leading to palpitations and abnormal P waves before QRS complex. Adenosine can be used to unmask the underlying atrial activity, but this is really not that significant of a topic, nor is there too much to talk about here. PVCs, premature ventricular contraction. Okay, there's something to talk about. So there's a bit of a problem in this kind of patient, right? Ectopic beats arise from ventricular foci due to hypoxia, fibrosis, electrolyte imbalances, or other causes. May lead to palpitations. You note abnormally wide QRS complexes followed by a compensatory pause. Treat cause, and if symptomatic, give beta blockers or antiarrhythmics. Okay, so in this image, you can see some premature ventricular contractions that are occurring. And so you're supposed to have normal QRS here, normal QRS here. Then you have this weird, funky thing. Okay, that's all that is. It would have to be in an ECG for you to really solve this. I've never really seen a question about premature ventricular contractions without the ECG. So you have to see something like this happening. Right. Ventricular tachycardia and ventricular fibrillation. Now, in these patients with fibrillation, you have to be very careful. Ventricular fibrillation is a huge topic with a whole scenario of its own, and there's a whole treatment mechanism you have to do. So this presents with a totally erratic, wide, complex ECG tracing that requires immediate electrical defibrillation. The ACLS protocol dictates beginning with unsynchronized cardioversion, and if fibrillation persists after 2 shocks, administer epinephrine. So you do a shock, you do a second shock, then you give epinephrine, perform a third cycle of shock, and then administer amiodarone if unsuccessful. There was actually a question in many Q banks where they made you, answer what would you do after 2 failed cardioversion. You give epinephrine, and then after the epinephrine, a third defibrillation. And after that, amiodarone. So you have to remember epinephrine and amiodarone here. Note that synchronized cardioversion is for patients with persistent tachyarrhythmia causing hemodynamic instability and rapid clinical deterioration. But in patients with ventricular fibrillation, you use unsynchronized cardioversion. There is no sync to actually work with in the patient with ventricular fibrillation. Whereas in atrial fibrillation, you use synchronized because there is synchrony with the ventricles. The ventricles are actually beating correctly. It's the atria that isn't. So you give a shock that's synchronized to the ventricular beat. Right? You don't want to mess up the ventricular beat. Here, once the ventricular beat is messed up, everything's going to go bad because the ventricle is the guy that sends blood into your brain and body. So you want to give a desynchronized where you're making a new sync occur and a new musical flow to help the patient regain their rate. Last thing is just dressage, which we looked at when we looked at QT prolongation earlier with the meds that were involved, as well as Joubert-Lodge-Nielsen and Roman-Ward syndrome. The main thing being that all you need to do is give magnesium, correct any hypokalemia or calcium derangements, any electrolyte derangements in general, and withdraw any offending agents if there are any that you can identify. In our next video, we'll move on towards congestive heart failure. I hope that reviewing these ECGs and looking at a few questions together was helpful, and we will continue on next time.